following paper was presented to the Second International Cardiovascular Congress in Scottsdale, February 1979. The System Approach to Cerebral Vascular Insufficiency. Brain blood flow is abnormal when it compromises function, structure, or growth and development. Normal brain blood flow is approximately 50 milliliters per 100 grams of brain substance. Flow must fall to 40% of this value before EEG changes appear. Tissue death occurs when flow falls to less than 20% of optimal perfusion levels. Our concern is blood flow to the brain and the factors that affect this flow. The system as a system. The cerebral vascular system is a part of the cardiovascular system, and both share characteristics and elements in common. Classification of the system as a system, separating the normal from the abnormal and the occlusive from the aneurysmal system, permits insight into patterns of disease, but not into the limits of tolerance to stress. In both man and the giraffe, blood flow to the brain must be maintained against the pull of gravity. Symptoms that develop when standing are not present when lying supine. The tilt table can detect this mechanism of producing brain ischemia. Other mechanisms that may reduce brain blood flow include myocardial infarction, hyperextending the head, hyperventilation, and dehydration. Blood is the common denominator. It is the plasma volume which greatly affects the hydraulics of blood flow to the brain. In the treatment of hypertension, plasma volume may be depleted by diuretic therapy. Expansion of the plasma volume may be critical to maintaining effective brain perfusion. Microemboli result from platelet aggregate thrombi, which form upon the ulcerated intima of the carotid and vertebral arteries. These emboli can cause minute cerebral infarction without a detectable reduction of blood flow. This patient presented with partial loss of visual field due to retinal emboli, despite the fact that symptoms did not recur with aspirin and persantim therapy. 3 months later, this platelet thrombus was present in the carotid artery. The relief of symptoms cannot be equated to the control of the thrombotic process. On the other hand, emboli within the vertebral artery selectively seek out the posterior cerebral artery because of its terminal origin from the basilar artery. This embolism to the occipital lobe caused acute homonymous hemianopsia and is clearly identified on the CT scan. The heart is a pump. It is primarily the mechanical effectiveness of the heart rather than its electrical activity that is relevant to cerebral perfusion. The purpose of a cardiac pacemaker is to improve the mechanical performance of the heart. The calibrated ocular pulse is a measure of the work of the heart. In this patient, unphysiologic right ventricular pacing resulted in a marked reduction of cardiac stroke output when compared to the output produced by physiologic atrial pacing and to that of normal sinus rhythm. The arteries to the brain. When a patient dies with a stroke, the heart and the brain are carefully examined, but the neck is never autopsied. Corrosion specimens of the cardiovascular system are commonplace and of great value. They permit the detailed examination of vascular channels, but the arteries of the neck are never studied in this way. More important, conclusions regarding the anatomy and pathology of the arteries of the neck are based more on the angiogram than upon actual pathological specimens. The validity of the angiogram must be critically re-evaluated in the light of pathological and clinical findings. A 67-year-old white male presented with a transient right hemiparesis. Ophthalmodynamography demonstrated obstruction of the left carotid artery. The angiogram was called normal. 59 days following the transient ischemic attack, this patient infarcted his left cerebral hemisphere, developed a flaccid hemiplegia and lapsed into a deep coma. 12 days later, he was dead. Current angiographic systems were designed to meet the imaging requirements of static obstructions, specifically the large atherosclerotic plaque. These systems are not suitable for the obstruction of short length, as in the kink, where the obstruction is but a single plane. The angioscope was introduced by Siemens in 1978. This system permits the use of ultra-short exposure times, either 35 millimeter, 100 millimeter, or cut film techniques, and magnification of any arterial segment in any head position with any projection axis. It is the first system design that meets all the imaging requirements of the cerebral vascular system. Arterial obstructions are basically of two types, the static and the dynamic. Static obstructions are usually atherosclerotic, constant and progressive in nature, which fosters the development of collateral channels. Dynamic obstructions may become total by head hyperextension with acute catastrophic symptoms. Collapse modifies the head position that is aggravating and symptoms are relieved. No collateral channels develop, and vulnerability remains unchanged. Furthermore, the significance of the arterial obstruction to a great extent is determined by the vascular beds which vary in their sensitivity to reduced blood flow. Vulnerable vascular beds include the collateral bed, the watershed, the overextended vascular bed, and the arteries of high resistance. The collateral bed. In this case of left carotid occlusion, the principal collateral flow is from the opposite carotid. This patient presented with a transient right hemiparesis and with severe sinus bradycardia. Right ventricular pacing was followed by infarction of the left frontal lobe. If the blood flow to a collateral bed is at a critical level, then mild reduction of cardiac output or of perfusion pressure can result in brain infarction. The watershed. The watershed is the terminal interdigitation of two vascular beds. The watershed between the carotid and vertebral system lies within the occipital and the temporal lobes. Reduction of blood flow to the watershed may be due to hypotension in a normal bed, hypertension in a diseased bed, or multiple arterial stenoses. In this case, carotid occlusion and vertebral obstruction resulted in a watershed infarction. Improvement followed carotid distal vertebral artery bypass. Flow from the vertebral artery is directed preferentially into the larger diameter, larger volume anterior and middle cerebral arteries, rather than into the small diameter vessels of the posterior circulation. Enhancing the vertebral artery flow to meet the increased flow demand results in the improved perfusion of both the anterior and the posterior circulations. The overextended vascular bed. When the carotid must supply the carotid plus the vertebral bed, then mild reductions of carotid flow may result in vertebral basilar symptoms and basilar artery hypotension. If this overextension of carotid flow into the basilar artery is the result of proximal vertebral artery occlusion, then vertebral artery reconstruction can restore intracranial blood flow patterns to normal. However, if the vertebral system is hypoplastic and the carotid arteries are normal, reduced carotid flow may be due to a failing heart. Arteries of high resistance. This anterior inferior cerebellar artery is an artery of high resistance because of its proximal stenosis. Of all the branches, it is the most vulnerable to the reduction of basilar artery blood flow. Arteries of small diameter and great length intrinsically possess high resistance, as does this atypical branch of the posterior cerebral artery, which arises from the siphon, extends to the occipital lobe, and anastomosis with the occipital artery. Superior cervical ganglionectomy may have a place in treating this type of small vessel disease. The brain and its blood flow. The measurement of cerebral blood flow clinically was first possible with the xenon technique. Positron emission scanning was an improvement. However, both techniques lack the potential for widespread application. The CT scan can not only image brain structure, it can also measure brain blood flow. Contrast enhancement of tissue is directly related to blood flow. Rapid sequence scanning records changing tissue density with the passage of the contrast bolus. Windows are selected and densities are determined in precisely the same window in each scan of the series. Flow curves are then constructed. Blood flow in one focus can be directly compared to that of the opposite side, or to any other focus at the same level. Moreover, brain blood flow can be measured below and above the tentorium in a manner never before possible. Indications for surgery. Brain structure and blood flow are evolving into critical factors in surgical case selection. Indications include the reduced regional blood flow, adequate brain substance, and accessible vascular obstruction. Contraindications include global ischemia or atrophy. In summary, the system approach is an integrated inquiry into all factors that critically affect brain blood flow. The conventional angiogram lacks validity for the obstruction of short length and for the dynamic obstruction. The CT scan offers the greatest potential for widespread application and for the measurement of brain blood flow below and above the tentorium. Regional brain blood flow is evolving into a useful criterion for the selection of surgical candidates. The system approach is the unifying concept that permits new insights into the nature of brain ischemia and new approaches to the solution of old problems. In October 1979, a unique seminar was held. The Lincolnshire Seminar on Brain Blood Flow in the 80s was the first attempt to implement the system approach. Recognized experts of brain blood flow evaluated a massive experience in CT brain blood flow measurement. Practicing clinicians in many fields correlated their observations with these new techniques. The proceedings of this seminar should be available in the first half of 1980.